Hi, everyone. I want to welcome Dr. Rashmi Kudesia. She is a board certified OBGYN and REI specialist in Houston, Texas. She is also the medical director for simplehealth.com, and she actually created a telemedicine algorithm for obtaining birth control remotely. You get to see a board certified physician remotely, and Dr. Kudesia is the one that designed the entire algorithm. And so I have had the pleasure of working with her at Simple Health as well. And so welcome and thank you for being here.
Thank you so much for having me.
Of course, of course. And so before we get into today's topic, which is birth control methods, can you just tell us a little bit about your path here and what inspired you to go into reproductive endocrinology and infertility?
Yeah, sure. It's kind of I guess, a different story than many of my REI colleagues. So I kind of knew I wanted to go into medicine for a long time. I, like many other South Asian immigrant children, have a physician in the family. My dad's a cardiologist, and I kind of knew that was where I wanted to go into medicine. And actually, I don't know if I ever told you this, I actually thought I wanted to go into ophthalmology for a long time. My freshman year in college, I took embryology, and that class just changed everything for me. Aside from the science of it, which is still to me very fascinating, I just had a really awesome professor, and we talked a lot about the impact of science on society. And so when we started talking about IVF and reproductive technologies, it just became really fascinating to me to think about what women go through. And I was so young then, but now, having personally kind of and professionally been on that journey, it's just so fascinating to think about how it impacts us as women for there to be IVF, for that to exist, and the pressure and the opportunities that it affords us. Anyways, I just got very wrapped up in all of that and started thinking that I wanted to go into the world of reproductive medicine. Spent a lot of time kind of studying the overlap between women's studies and reproductive medicine, and then went to medical school, and the rest is history. Just 11 years of training later, here I am.
Yes, and I'm so fortunate that I can text you with all my REI questions. So thank you for being my on-call doctor. And so today it's kind of interesting because you help people have babies,
Yeah.
and we're going to talk about how we can not have babies. So a vast knowledge of birth control is definitely necessary to be in your field. And so
Yeah.
let's just start off with the basics: hormonal versus non-hormonal contraception, and go ahead.
Yeah. Well, and we can definitely talk about this a little bit later, but I think it's also really important to say right at the outset that a lot of times people are using hormonal contraception for non-contraceptive purposes. And so, we do a ton of that even in the fertility world. So we can circle back to that later. But yeah, when it comes to contraception, of course, I agree. I always break it down into hormonal and non-hormonal options. So in your non-hormonal choices, those are kind of the most basic. Obviously, the first thing that often comes to mind are the barrier contraceptives. So condoms, male or female condoms, diaphragms, things like that. So that would be in that category. I think we can also talk a little bit more about fertility awareness method, or sort of also sometimes referred to as natural family planning. So those are kind of as a whole other category. And then when we look at the hormonal methods, there are kind of two subcategories there. The entire idea of hormonal contraception is that it includes at least progesterone, okay, which is one hormone that our ovaries typically make after ovulation, and then may also include estrogen. And so that's, estrogen and progesterone are the two ovarian steroid hormones that are produced at different parts of our cycle. And so from the brain's perspective, when we're taking these hormones, especially if we're on an estrogen containing contraceptive, it can sort of be interpreted by the body as, okay, the ovaries seem to be producing hormones. We don't need to be stimulating the ovary to do anything. And so it kind of shuts down our reproductive axis that way. And so particularly, again, for women that are taking combined estrogen, progesterone contraceptives, basically they're just telling their ovaries, hey, you don't need to ovulate, and let's just pause the whole reproductive process. And then for the progesterone only option, so those are ones we often use if somebody has a contraindication to being on estrogen from a medical perspective, if they're breastfeeding, which is a journey that, we both have been on. And so we can talk about that too. Those are some reasons that we may not want to use estrogen. And so there's kind of those subcategories there.
And the reason to not use estrogen in nursing and in those situations is because it would stop the production of milk. Is that why?
Yeah, so in lactation, once you have estrogen on board, it definitely drops milk supply, and it is often mimicked. So, for example, once women start ovulating again, same thing. Women are often familiar that their milk supply will drop once they start to ovulate again after a delivery. And so, same concept. When you get estrogen through a estrogen-containing contraceptive, same thing will happen. But the progesterone doesn't really seem to have that impact. And so, whether it's through a progesterone-only pill or whether it's through a IUD, like an intrauterine device, or an implantable device. Those are all ways of getting progesterone. Those are all of the options there.
And is one like the combined versus progesterone only, is one more or less effective than the other?
Yeah, so that's a good point. So they're both quite effective, but the progesterone only mini pill and needs to be taken very regularly. So usually within like an hour at most buffer day to day. And so that can be tricky, especially for women that are taking it postpartum, right? And they have a newborn, your schedule is totally crazy, and so that it can be a little bit tricky, which is why postpartum many people opt for an IUD or an implantable device, something you don't have to think about. But that's the main difference as opposed to estrogen containing contraception. Yes, of course, you should still try to take it regularly day to day, but there's a little bit more wiggle room if you miss a pill or you're a little bit late.
Yeah, I don't know like like the day of the week, let alone the time of the day right now. It's just felt like one long day since my newborn has been born.
Yeah.
I'm obviously very grateful to have him. And before we actually keep going, I do want to mention that Simple Health is giving everyone watching this lecture a free consultation because both Rashmi and I started help to get that company off the ground, and you can just use code FemHealth at simplehealth.com for a free consultation if you're looking to get any kind of online birth control through a telemedicine visit that was designed by Dr. Kudesia herself.
Yeah.
So feel free to use that code and tell your friends if they're interested in getting a telemedicine visit for birth control. All right, so we talked about the mini pill, we talked about the combined pill, IUDs, and let's talk a little bit about, I want to circle back to the family planning method because
Yeah.
I know a lot of people may want to use it. And then we also, like, I know I used it to actually get pregnant because
Sure.
I was monitoring my cycles to help optimize my fertility. So talk to me about not getting pregnant and really how effective is it to use that?
Right. Okay. So when it comes to, there's kind of a name or a misnomer to all of this, or it's kind of like a categorization issue. So you hear the terms, natural family planning, fertility awareness, you hear rhythm method, calendar method, and these aren't all exactly the same thing. So I think when we're talking about fertility awareness methods for contraception, the only one that has any level of even vaguely acceptable efficacy to it, I think will be what we call the symptothermal method, which is basically a combination of tracking your symptoms leading up to ovulation and then your actual basal body temperature. And so, yes, a lot of us do some version of that when we're trying to get pregnant. But as I often tell, my patients, when you're trying to get pregnant, sure, the more input that you're getting, the better in that regard. But the worst case scenario is that you interpret, the symptoms wrong, or your thermometer is off or whatever, and you miss an ovulation, or potentially you miss that you're not ovulating, which, these are all frustrating things that can happen because it just delays you from getting to where you need to get to. But the opposite when you're using contraception is that obviously you could have an unintended pregnancy, which is a pretty severe side effect. And so, what I typically would say, so first of all, like I said, to be effective, it should really be used by women that have very regular cycles. So this should be people that are cycling regularly, meaning that their period tends to come every 24 to 38 days. And so, people who menstruate, definitely if you're thinking about this method, you want to be tracking your cycle. So that's the first step. Most of us might use like an app on our smartphone, but you can use a pen and paper calendar, however worked for you, but track your cycles. And honestly, before you can really say that you're a great candidate for this method, you should be tracking your cycle for at least 6 months, I would say, if not a year, and kind of know what your pattern is. And so if you're following regularly within that window, the other thing you
Can
want to
I
be,
ask you a quick question?
yeah,
So you said 24 to 38 days, but that should be like the same every cycle, right? Like it's not like I should always be at, if I'm going to be at 30 days, I should always kind of be at 30 days. Like you need predictability. Or can I
yeah.
be
So
at like
that's
28 days and then 31 days and then 24 days?
So that's okay. I'm so glad you pointed that out because that makes a big difference. So, some women have, they have a clockwork 28-day textbook menstrual cycle. That's actually a minority of women. About 15% of women have that, which so it's funny because that's the textbook chart, but a minority of women have that. What a lot of women will have is that they might have some months it's 27 days, some months it's 29 days. Okay, so that's even a little bit, more workable. When you are somebody that is having 1 month it's 24, then 1 month it's 30, and it could be anywhere in between, what that ends up meaning is that your day of ovulation is going to vary, right, month to month. So you're probably still ovulating, but it's varying a little bit or almost by a week. And so what that means is when we talk about the symptothermal method, the idea is that we kind of calculate, okay, well, we're kind of watching to see as you approach those signs of impending ovulation, like your cervical discharge changes and all of that. And then when your temperature goes up as tested by a basal body thermometer, that's your confirmation that you have ovulated. So when you're using this for contraception, either you have to be really able to reliably tell, hey, I get these symptoms like my cervical discharge changes before ovulation, or you have to just put a buffer. Okay, well, this is where I generally ovulate. So this whole week, plus minus a couple days, I'm just not going to have intercourse. And so if you're somebody that has irregular cycles, your window of when it's less safe to be sexually active becomes a lot bigger. And so for some people, that's part of the reason that it's just not tenable. And in fact, there are things like this. There are various methods that you can use to calculate this all out. And some of them will take into account, like, here's your shortest cycle, here's your longest cycle. Again, give a couple days of buffer, and then that whole window is like a no-go zone. But for some people, that could be half of the month. And that not only requires, if you're in a heterosexual relationship, requires obviously both people to be on board with that concept. And for many people, like I said, it's not tenable to be, not available to have intercourse half of the month, plus, you have your period on top of that. So for many people, that's a lot of abstinence, but may not make that the best method.
Right. I mean, I think at that point, you may want to use that method if you could feasibly have a child in your life at some point. Like, so that's definitely something to consider. And it seems like it requires a lot of work too. You have to check your temperature every day.
Yeah, so you have to check it every day. It's actually first thing in the morning. So you have to buy a particular thermometer. So you can't do this like with your average thermometer that you might have at home. You have to buy a specific basal body thermometer, and it measures your temperature to the 100th degree. So it'll be like, 97.92 or whatever. It's a very specific thermometer. You do it first thing when you wake up in the morning. So you can't like run to the bathroom. You can't scroll on your phone. You have to do that first thing because that can impact your temperature. And so, yeah, you kind of have to get into this lifestyle. And for some people, it really works. I don't want to downplay it, because for some people, I think it's very empowering. They feel like they know what's going on with their body. They can read and interpret their signals. And I do think that can be very illustrative and it can just feel good for some women, but for other people, it's not. And I think my message is just, you should do the method that works best for you and your lifestyle. Because I think with COVID, many of us are not traveling as much, but that's the other thing, certain things, travel, time zone changes, changes in your alcohol intake can potentially all impact your signs and symptoms of ovulation. And so for some people, it's just, it just doesn't fit their lifestyle, and that is totally okay. And the other thing I want to say about COVID is that stress, can also throw off your cycle. So I have a lot of women that I'm talking to that their menstrual cycle is shorter or longer than it's ever been before. So again, anytime something crazy is happening in your life or in the world, if you're using a non-hormonal method or some sort of method relying on your symptoms, you have to be a little bit cautious that you may experience changes that you're not used to seeing.
Yeah, I think the bottom line is be informed and be diligent if you're going to be using that method, and it works well for some people. And as long as I feel like you're probably on top of it, it could be pretty effective.
Totally.
So what about our just regular, barrier methods, and sort of what are the most effective to least effective in that realm?
Yeah. So when we look at those, the real thing to remember is sort of the perfect use versus real world use differences in success in sort of success rates at preventing pregnancy. And so I would say, in barrier contraceptives, the most commonly utilized are going to be, condoms, particularly the male condom is probably far and away the most commonly utilized. Although I think increasingly the female condom is being, considered. And I think for females, I think for women, sometimes people really prefer to be able to be in charge of that. And so that can be kind of cool as well. And you compare that to things like intrauterine devices, IUDs, or implantable devices, those are kind of in our long-acting reversible contraceptive category. Those are like almost 99% effective. They're almost as good as getting your tubes tied, like in terms of permanent sterilization, but they are reversible. So, there's kind of a spectrum, but those are, our most effective options, and they're really good.
And how about the combined pill with pretty good use?
Yeah, so that's like in the 90s percentage wise, especially if it's an estrogen containing pill, because again, those are more effective. They work in more ways throughout the body to prevent a pregnancy from happening. So yeah, those are really quite effective. And I think as long as you're using it regularly, I would feel good about that. The chance of a unintended pregnancy happening with perfect or near perfect use of a combined estrogen progesterone contraceptive is really low.
Yeah. Yeah, that's what I pretty much use for most of my life. I actually started using it because of acne, not even, when I was very young. And it's probably a discussion for another day, but we can talk about how people are trying to control what kind of birth control women are trying to use.
Yeah.
That,
That is a whole other topic.
that's a discussion for another day.
Yeah.
Any myths that you want to bust about birth control, or any other sort of, juicy tidbits of information you want to give our audience?
Yeah, for sure. So the number one, I obviously have to say this as a fertility specialist, the number one misconception and the truth of the matter is that birth control does not impact your future fertility. That is so important to understand. What does happen is that when you are on birth control, you are having kind of these withdrawal bleeds. These periods are not your real periods driven by your ovaries activity. And so I see all the time people come in and they're like, oh yeah, my periods are regular when I'm on birth control. And I'm like, okay, well, of course they're regular on birth control because the birth control is controlling your flow. And so, what the real thing is in terms of tracking your cycle is when you are off of hormonal birth control. And that's the only time that you can actually see what's going on with your cycle. So what I often say is that the only way that birth control can sort of contribute to infertility is that if you're on it for like 10 years and time has gone by and you've not noticed, because you couldn't notice the changes that were going on in your cycle, when you come off, you might be surprised to find that because of time, changes in your health or your weight, that maybe your cycle has changed. It may become regular or irregular, it might be longer or shorter, all of those things. So there can be changes, but the only way, that birth control is contributing to that is by not kind of allowing you to see the changes that are happening in real time. But otherwise, within a month or 2 or 3 of coming off of normal like birth control pills, for most women, their ovaries will be back to where they would have been otherwise. The only contraceptive, we actually haven't talked about it yet, that has kind of a longer impact in terms of return to fertility is the Depo-Provera injection. So that's one that you get every 3 months. That one can take up to like 9 months to a year to have like a return of ovulation after that. So that's the longest one, but the rest can be, even in another myth is that people often think that they will not start ovulating right away after they come off of birth control. Some people do take some time, but other people come off of it and boom, are pregnant right away. So, that's the other thing.
So be ready if you are coming off of it to have
exactly. And if you're coming off of it to get pregnant, then you should get on your prenatal vitamin right away at the same time. So that's kind of the other good advice there.
And I know there's a lot of questions about, if I just don't take the placebo and continue to take birth control so I can skip my period. Is that okay? Is it safe? Is any downside?
There's no downside to that. So it's totally safe. In a history lesson, the birth control pill was designed to have that off month, the bleeding week, really to try to fall in line with the Catholic Church. They were really trying to get the approval of the Catholic Church. And they thought that by having this period every month, they would be more likely to gain that approval, which it did not. But that's really the only reason. There's no physiological reason to have that bleed. Again, it's not a period, it's a withdrawal bleed. So there's really no reason to have it. So, and in fact, for some women that are on certain contraceptives, like a Mirena IUD, like a progesterone eluting IUD, they may not get their periods. About a fifth or more of women won't get their periods periods at all in that method. So totally fine, totally safe. The only advantage is, I think for some women, they really like to get their period every month just to know that they're not pregnant. That's one reason. But there are a lot of reasons not to. For others, again, they may they may travel, they may have jobs that require them, make it difficult for to always have, menstrual hygiene products. They may find that they have a lot of pain or discomfort or heavy bleeding with their periods, so they'd rather space it out. If they're anemic, there are a whole host of reasons why you may not want to have your cycle every month, and that's totally fine.
Awesome.
It's a preference.
Yeah, no, it's funny because like in your 20s, I totally felt that way. I was like, oh, thank God I got my period. And then in my 30s, I'm like, oh, damn it, I got my period.
Yeah.
Like, oh, I'm not
I
pregnant.
know, it's one
Damn
more
it.
thing to deal with.
Yeah, it's like pendulum swing to the other side when you get to your late 30s there and you're trying to conceive, or early 40s. Well, no, this was super helpful information. And I guess one more thing that we should probably touch on before we sign off here is lactational amenorrhea. We want to obviously tell everyone about the effectivity of breastfeeding and as a birth control method. So I will let you take over.
Yeah, so same thing there. So the hormones of lactation also suppress the ovarian activity. Now, that being said, for every person that is breastfeeding, there's sort of a certain set point at which ovulation will pick up again. Typically happens around 6 months or later, but can happen before that too. And when that happens, what will happen is that first you will start, kind of having these pre-ovulation symptoms. You will ovulate, and then if you do not get pregnant, you'll get your period. Okay, so the important thing about what I just said is that first period that tells you that you're probably ovulating again comes after you've already ovulated. So if you are not using another form of contraception and you are having intercourse with a guy, you can get pregnant again that way. And so lactational amenorrhea, works well, I think, if you are fully breastfeeding. Again, if women are finding that they didn't have good breast milk supply, which I struggled with, is definitely a real issue. That's another reason that, I would not rely upon that method. And so truly is best studied in women that are directly breastfeeding, not pumping, directly breastfeeding, full breastfeeding only. And again, with the understanding that your first ovulation will definitely come before you have a period, and may even be before you notice those symptoms. So that's the only caveat. Consider your options before you go there, but it can work.
Okay, awesome. All right. Well, it was great to chat with you. Before we sign off here, can you sort of let everyone know where they can find you on social media, your website, if anybody wants to, see you in person, if they're in the Texas, Houston area?
Yeah, sure. So I practice at CCRM Fertility Houston in Houston, Texas. So you can find us or find me through the ccrmivf.com website. I'm also on Facebook and Instagram my handle is at rkudesia. So it's RKUDESIA.